We'll just trim that out.
Okay. This is our assessment of the abdomen. We just finished our history. We're going to begin with inspection. We're going to note, make sure there's no jaundice, no cyanosis, no redness, no bruises, no discolorations. We're going to check for nodules, lesions, or scars. We're going to check for venous return. We're going to press and separate our fingers, milking and emptying the section of the vein. Release with one finger, and then note the time to refill. And above umbilicus should go toward the head. Below the umbilicus should go toward the feet. We're going to note the contour. Contour can be flat, rounded, scaphoid. No distensions or bulges. I'm going to have you take a deep breath. And any masses or hernias should be seen when we have our patient take a deep breath in, or he could lift his head. And any masses, that's good, or any masses, hernias, or muscle separations will be noted after the patient lifts his head. We're going to note that his respirations, his abdomen is moves smooth, it's even. We're going to see if there's any aortic pulsations. With a thin person, it would be, it may be visible, but it should never be marked. Next, we'll move to auscultation. And we're going to auscultate the 4 quadrants. Upper right, upper left, lower left, lower right. We should be listening for clicks and gurgles. It should be 5 to 35 sounds per minute. If it's absent for 5 minutes, where we hear no breath sounds at all, or no bowel sounds at all, this could signal an emergency. We should high-pitched tinkling could be signs of an early obstruction. Decreased bowel sounds could mean peritonitis or paralytic ileus. Increased hunger or increased bowel sounds could mean increased hunger or gastroenteritis. And now we're going to listen for friction rubs over the spleen. And over the liver. Next, we're going to listen to for bruits. I'm going to use the bell again. The aorta, renal arteries, iliac arteries, and femoral. We'll also listen for venous hum around the umbilicus, and the epigastric area. Next, we're going to move to percussion. Should be tympany over, we should hear tympany over the stomach and intestines, and a dullness over the organs like the liver or the spleen. So now we're going to check the size of the liver. So we go from area tympany, from mid-clavicular line to an area of dullness. we would mark that area, and then we go from an area of residence to an area of dullness. It should be 6 to 12 centimeters and 2 to 3 centimeters in depth. Sorry. Take a deep breath. Good. And the spleen, we would check from an area of residence to an area of dullness. Take a deep breath in, and we would hear tympani. Okay, now we're going to assess the gastric air bubble. Left lower anterior rib cage, sorry. The gastric bubble should be, the tympani should be a lower pitch than the intestinal tympani. Now we're going to percuss the kidneys. Go to your side and just strike. The patient should just feel a thud but no pain. And we would do both sides. Now we're going to move on to palpation. We'll start with light. First I want to ask if you feel any tenderness anywhere.
No.
Okay. If you felt any tenderness anywhere, I would save that area for last. So we start with soft. Should feel smooth and soft. No any resistance or tenderness. Then we would move on to moderate palpation. We can use the sides of our hands. Then we're going to move to deeper palpations and see if we can feel any masses. If we felt any, we would note the shape, size, and tenderness. So we're going to feel the liver. We take a deep breath in. It should feel smooth, it should be firm, smooth, and even. The gallbladder would be below the liver. And a healthy gallbladder would not be palpable. Next, we'll go to the left side to the spleen. Take a deep breath. And the spleen should not be palpable as well. That would mean an enlarged spleen. Now, the kidneys. I'll put one hand underneath. And I'm going to have you take a deep breath in. Good. So we would feel the right side more than we would feel the left side. Now we're going to feel the aorta. And then the bladder, if it was distended with urine, then it would feel smooth, round, tense mass. Also, it would also, if we palpated or if we percussed it, it would also have a dull sound if it was filled with urine. Next, we're going to do check for rebound tenderness, and that's where we're going to push down, and then the patient would tell me whether he felt tenderness when I pushed down or when more when I let go. Next, we're going to check for the iliopsoas muscle test. So the patient is going to raise his leg. I'm going to ask the patient to raise his leg, and then I'm going to push down as the patient raises. If the patient had felt pain, we would suspect appendicitis. Next, we're going to do the obturator muscle test, and this is where we pull in. If the patient felt pain here, that could mean we could suspect a ruptured appendix or a pelvic abscess. Next, we would check for ballottement if we thought there were any masses. We can also do the scratch test for the liver. We would put our stethoscope over the liver and we would scratch. And when we were over the liver, we would hear it. It would intensify over the liver. Next, we could check for ascites. So I'm going to have you roll on your spine. And we would press down. And we would palpate. And you would hear tympany. Because and we would hear dullness if there was fluid filled. And that is our abdominal assessment. Thank you.